This is Impact Healthcare.
Attention. This podcast has been disrupted.
Welcome back to another episode of the Disrupt Healthcare podcast. I love the new name, and I'm excited to have a new guest, but a familiar face. I almost said old. A familiar face, Miss Deb Alt. Deb, for the people maybe in the audience that have never heard of who you are or your great company, give us an introduction.
Well, fabulous. I'd be shocked if there are many that haven't heard, but my name is Deb Alt. I'm a registered nurse. I'm the president and founder of AIM. We're a team of nurses and doctors that come alongside patients, primarily telephonically, but through some other tech stuff too, to help guide them through the two most cumbersome ecosystems in the universe. The healthcare delivery system. So, how do I get the best care from the best providers? What does the science and math say is going to cure me of this horrible condition? And the health plan system. Oh my golly, how do I avoid bankrupting my family and my employer as I'm going through this recovery process?
So Deb, we were prepping for this, and I told you one of the things I have been noticing about myself specifically is I get so entrenched in the conversation about the impact for the employer, right? The plan sponsor. I want to start this and flip that on its head because in your introduction, you always introduce yourself as the team of nurses and docs that come along the side of the patient, the employee. So I want this to be focused a lot around that employee. And so we talked about best and we talked about bankrupt, right? So both sides. When we think about the word best, that's an interesting thing in all subjects, but in healthcare specifically. If I'm buying a car, I can go on Consumer Reports, I can go on all sorts of things and says this rating and this rating. I love Range Rovers, but they're pretty cars, but they're crappy, so you can kind of see that, right? When we think about best in the patient experience, are we talking about like Google reviews and like they have ugly wallpaper? What are we talking about best on that side?
Well, yeah, I will tell you, we do tap into Google. I think I looked earlier today, it's number 18, 19, 20, and 21 in our pecking order of things that we look at. So we do Google Dr. So and so indicted, Dr. So and so arrested, Dr. So and so obituary, Dr. So and so retired, because Google's the only place you can find that data, but that's about the only data that you're going to get out of it that is any good. You really have to be looking at objective quality tools, not Yelp, not Angie's List, not Google reviews, right? So we currently license over 40 different quality and cost transparency tools that go and pull data, objective data about clinical outcomes, infection rates, morbidity, mortality, readmission, complications, functional outcomes. Did they cure the condition, right? If you have somebody who has spine surgery and they end up paralyzed and not able to walk, that's not a good outcome. So there is no single Consumer Reports of healthcare yet. Working on that, right? But it doesn't exist yet. So that's where you have to insert someone who can go in and analyze. And let's face it, what are the two subjects that Americans hate the most? Math and science, right? And what are the two subjects you most need to rely on when it comes to healthcare, especially in the US? Science for quality of care and math, right? So bringing that into the equation with the patient and having an unbiased patient advocate, a nurse, right? We love our patients. We want to crawl through the phone and hug them and tell them it's going to be okay. We'll help you. But bringing that logic into a highly emotional and volatile conversation.
So Deb, for maybe people who heard that and like, all right, makes sense, but how does that have anything to do with the way healthcare is conducted, performed, paid for, whatever? Let's personify this as far as like a plan is concerned. So in this conversation, an employer offers health insurance to their employees, and today they grab a normal product off the shelf. It has a blue color, a Cigna color, or whatever color. And tomorrow they have a company like yours. What does that look like? What does that feel like?
Yeah, it is a change of mindset for sure, not just at the leadership level, but at the patient level. And I will tell you, it takes a minute because here's the thing. You got to understand, starting back in the 1960s, providers and insurance companies started patting patients on the head and telling them, it's okay, dummy little you. You can't have the conversation with the insurance company. It's too technical. It's too hard. You don't understand the vernacular. You don't know the codes. And that was a lie, right? I come along and say, it's your body, it's your wallet. Of course, you want to be involved in that. You, as the patient, you need to call the nurse. You need to, and we know, and our statistics show over and over, patients are much more successful at telling us what's going on, what conservative treatment options have been tried, what the date and mechanism of injury was, what the doctor said, than what the secretary at the billing clerk's office is able to do. So the success rate for authorizations, you want to solve the prior auth problem in the United States? Stop letting providers do the prior authorizations. That's the solution. Let the patient do their own prior authorization because the denial rate when a patient does their own prior authorization is less than 1%. When a doctor's office does it, it's 7%. When a facility does it, it's 11 to 17%.
So,
Patients are
Deb,
that much better.
so somebody who hears that and says, who the doc doesn't know as much as the patient on what the patient needs, or are you just more saying the thoroughness of the conversation able to be had?
Yeah, because how often do we actually get to talk to the doctor?
Yeah.
Very seldom. It's usually somebody in the billing department, and I'm convinced they've got that poor gal chained in a dungeon with a candle and a quill, and she's digging through some electronic medical record that doesn't even have a box for date and mechanism of injury. And I need to know date and mechanism of injury because I'm trying to look at, should this be work comp? Should this be under their auto policy if it's out of a car accident? Or did they, kick the dog in the middle of the night, Saturday night, going to the bathroom? And of course, it's under their major medical. So patients know that information and are able to communicate it much more clearly, efficiently, effectively than what the system, the healthcare system, is currently set up to do. The other part of that, though, is let's say I had this actual case happen the other day. A provider called and they were ordering a MRI and they wanted it done at the hospital. And I'm like, that doesn't make any sense. We all know you don't want a hospital to do your MRI. You want to go to an independent imaging facility, right? And they couldn't explain to me why the doctor was adamant that this had to be done at the hospital. We get the patient on the phone, and as we're talking to him, it becomes very apparent to us why the doctor is insisting on the hospital because the hospital has an open MRI machine. This patient weighs over 600 pounds and will not fit into a tube MRI machine at an independent facility, right? Had the patient just called us, we wouldn't even have had that whole dialogue back and forth with the doctor about, well, I can't certify it. I'm sorry. I'm going to have to talk to the patient. If the patient would have called first, easy peasy, done. Yes, this makes perfect sense. It also solves a lot of your denial problem, right? Providers are frustrated about getting denials from insurance companies, and rightfully so in many circumstances.
Mhm.
But when the patient already has that information, if the patient is engaged and involved and we're able to have that dialogue with them, let's say that guy really should have been going to an independent imaging facility, right? He weighs 160 pounds and we should be going to the independent imaging facility. I can redirect that right then and there, easy peasy, lemon squeezy. Hey, here's why this is the higher quality option. Here's why it's the more affordable option. And all's done, right? Instead of a ton of back and forth and rigmarole and things being delayed. And, I can do with a patient an imaging pre-cert in 6 minutes. With a provider, it's a back and forth for 3, 4 days trying to get the data, trying to get the information. That's why you get these long periods of times. That's why you get high denial rates.
And so when we think about this, again, in the practical nature of A, the patient, and B, how this works in the design of the overall health plan, this is, hey, instead of Becky going to Dr. Jones and then Becky not being involved in any of this other stuff, you said, hey, this is a change. So we are asking Becky to be more involved in her own healthcare. But in this scenario, they have a team of nurses that they're picking up the phone saying, my doc said I needed an MRI. That's now a conversation with Becky. Walk me through what that conversation looks like with Becky.
Yeah. So, number 1, we're nurses, right? We're patient advocates. The first thing they teach you in nursing school is how to wash your hands. The second thing they teach you is how to stand in between the doctor and your patient. Protect your patient at all costs, right? You're the last line of defense for somebody who is incapacitated, ill, not at 100%. So, we take that role very seriously. So, we say to Becky, I'd be happy to help you with that. Tell me a little bit about what's going on. And Becky typically starts pouring out her heart. Well, this happened, da, 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 and I elevated it and I put ice on it and it still wasn't any better. And then we did physical therapy and I had an x-ray and they yammer all that stuff out. Behind the scenes, I'm checking off boxes for medical necessity and appropriateness, right? And then we talk about, okay, did he tell you where to go to get the MRI? Right? And is that the best place? And we're looking at your plan design. Is there an incentive? Is there a direct contract? Is there some preferred relationship for you to obtain that procedure or service? And can we get you there? And the other side of that, do you have transportation? If it's your right foot and you can't push the gas and the brake, who's going to drive you to the MRI? So it's really much more of a hand holding, taking care of the patient kind of experience. The other part is we just had this come up. We have same patient, 660 pounds, right? Has tried everything under the planet, can't lose weight. This patient probably needs gastric bypass, not a covered benefit under their health plan. It's just not gonna be covered. But the patient needs it, so we're doing our best right now to get him hooked up with a foundation, to get a scholarship, to get the gastric bypass that he needs. Because the MRI is just the iceberg of the issue, right? It's just the top of the iceberg. What we really need is to get him healthier overall, and now's our perfect opportunity to do that. We had a diabetic patient that we've been trying for 3 years to get engaged to talk about better diabetes management. Finally, we get a request for a CT scan because of sinus infection. And we're like, here's our golden opportunity. And we say to the provider, I have to talk to this patient. In order to finish this, I have to talk to the patient. So the provider calls the patient, says, this is weird, but your insurance says they have to talk to you to finish it. We finally get her engaged on the phone and we're saying, hey, we're walking you through this. By the way, if you have diabetes and it's not well controlled, you're more prone to infections like sinus infections. How's your blood sugar control going lately? And now that entire gate is open to start talking about what we've really been trying to talk to her about for 3 years. And now she's more engaged in controlling her diabetes. Now we can avoid her having to have sinus surgery, right? So it's all about timing and willingness of the patient to engage and taking advantage of that minor acute event that really is just the part of the iceberg that you're seeing and getting to the root cause and fixing it.
So thinking about that same exact scenario, old versus new, right? Hey, I have my normal ID card for my normal insurance. I would have gone to my doctor. The doctor says I need the CT scan. They would have pre-auth the CT scan. I would have had my CT scan. They would have said your sinuses are blocked and potentially now you have surgery. That's row A. Row B is you intervene. Now that's a conversation, uncontrolled diabetes, which could prevent the sinus surgery from ever happening, but really start digging in the root cause of the issues in the first place. So then my logical brain says to me, well, wait a second. Health insurance, the key word in that sentence is health. Why wouldn't the health insurance company want to do this or do this today? What is the rationale to not to like this seems like it would be a better patient experience. Like we all have access healthcare. It's hard. Even when we're in the business, this is hard. It can produce a better outcome, i.e., I didn't have to get that sinus surgery. What's the rationale on the other side?
Well, I think you probably put it best in the documentary. It's not personal, it's just healthcare. It's misaligned incentives. And while some regulations are well intentioned, we always end up with the law of unintended consequences. When you put an MLR ratio cap of 20% in play, you instantly eliminate the insurance company's motivation to control claims costs. And, whether insurance companies ever cared about patients or not, remember I said back in the 1960s, we started patting people on the head and telling them, no, no, we'll take care of this for you, right? Whether they intended that to cut the patient out or not, the fact of the matter is, most of the time, if a patient even attempts to call a status quo traditional health plan and they actually get through to somebody after however long on hold, sometimes hours, and they are identified as a patient as opposed to a provider, and they get anything other than hung up on, we're shocked, right? Because insurance companies are not patient facing, they're provider facing.
Mhm.
And so that patient experience is completely different in that traditional status quo because the system is designed not to be a servant and an advocate to the patient.
So, for those people that might not be nerds like us, Deb talked about the MLR, the minimum loss ratio rule, and that was a provision inside of the ACA that basically capped the profit an insurance company could make for every dollar of premium that they charge. Again, the intention, well intended, was like, hey, we don't want the health insurance company gouging patients for profit. So we're going to cap it at this percentage. Well, this is just an arithmetic conversation that says if you cap the percentage of profit that I make per dollar, how do I make more profit? I charge more dollars. This is just math. And so, any of you listening to this, I encourage you to lift that up if you are in a fully insured arrangement, because again, it's math. You're never going to be in a scenario where you are going to win because you winning is them losing because unfortunately you're sitting on different sides of the table. Deb, I want to take the last part of that, the care part of it, into one of the things that in my career I have been most shocked about is the few things that in this side of the fence, when you mandate, encourage, incentivize people to do it, at first they might go kicking and screaming, and then they're like, oh my God, thank you so, so much for doing that. Talk to me about, okay, hey, I've got this team of nurses over here that's part of my health plan design. I could call them. What are employers doing to, because it sounds cool. Like, hey, I have this ailment. I need help with it. I might as well call this person who knows more about this stuff than I do. This is great. I'm a widget maker. I'm a manufacturer, or whatever it is. How does it go out of the gate? What are the patients saying? And then what happens, 60, 90, 120, 180 days? Talk to me about the patient side of that.
Well, a lot of that, Lester, is led from the top down, right? So if the leadership at the organization truly loves and cares for their employees, and their employees have already kind of got that gist to start with, and then they come along and say, this is better. It's different, but it's better. And they already have that trust built with their employees. It's a different scenario. right, than if your employees have already envisioned you as only giving a hoot about what things cost. So some of it is cultural. But I will tell you that it is a shift in mindset. All of a sudden, we're asking patients to call. And day one, they're like, "What do you mean I have to call? I've never had to call before. My doctor always did it." They don't understand that that really wasn't in their best interest, right? So, an incentive like waiving deductible and copay goes a long way to help that because it's really easy to walk into an open enrollment meeting and go, "Listen, if you remember nothing else today, call the nurse first, follow the nurse's guidance and advice, and your care becomes free. We waive your deductible, we waive your copay. We're going to guide you to the best care from the best providers, the highest quality. And because we know you're going to get healthier faster, and that's going to end up being cheaper for us, we're going to make it cheaper for you too by waiving your copay and deductible." Right? When you can approach it that way, and people understand they really want to get me healthy. They want to get me healthy quickly. They want me to be at my best. And they're willing to make something that 64% of Americans say they've avoided healthcare because they're afraid of the expense, right? And when you eliminate that barrier for patients, in the beginning, it's, "What do you mean I have to call?" And then it slowly becomes the positive water cooler talk helping of, "Did I call?" Let me tell you, I had a law firm customer not too long ago, Midwest, about 115 employee lives. There were these 3 women who were influential, right? They're not partners in the law firm, but they were pretty influential in the law firm, who were absolutely irate. One of them had been with her OBGYN for over 20 years, and they went into this type of a plan. She called, her OBGYN had sanctions against his license in 8 states. So we could not certify that care with that OBGYN for her visits at the guided level to waive her copay and deductible. She was gonna have to pay her deductible and her copay just like she did last year if she continued to see that doctor this year, right? She was irate that we would not certify him as guided. Another woman, pediatrician, not board certified in pediatrics, but she wanted him certified at the guided level so it would be free. She didn't want to keep paying her copay and her deductible like she did last year. These 3 women threw such a fit and were so vocal to the leadership at the law firm that when they got to month 9 and it was renewal time, they called an all hands meeting. They put everybody in a conference room, and the leader of the practice said, "Listen, it's time for us to decide, are we going to stick with this kind of health plan or are we going to go back to the traditional status quo, fully insured kind of thing that we had before?" And, I want to know, what do you all want to do? So, of course, the first 3 people to speak up were these 3 women, right? And then a woman stood up and talked about how she was going to go to Dr. So and so for her gallbladder surgery. But because she called the nurse, we guided her to a different path for her gallbladder surgery. She got it for free. She had a great outcome. And afterwards, as she was telling her family and her friends, she was going to go to Dr. So and so, and we got her. She started to find out that, wait a minute, everybody thinks Dr. So and so is horrible. Thank God you didn't go to him. Horror story after horror story. The next person gets up and talks about prostate cancer that is now completely cured with $0 out of pocket spent to get to that cure. Another gets up and talks about their child with cystic fibrosis and how they'd been needing to get a percussion vest. And the last 5 years, they've been fighting with the insurance company trying to get it. One phone call to us, and we start talking about, well, yeah, that's usually not covered under insurance, but have you talked to anybody at the Cystic Fibrosis Foundation and got them into a community resource where they got that vest for free for their child, right? So person after person after person got up and said, how could we leave this? How could we leave this, right? At the end, when they voted, it was 3 people against, everybody else for, right? So it does take a minute, right? The first 30 days is like, what is this? Why is this going on? who are these people? I have to do all this extra work. And then once people start to do it and start to see the benefits of it and see how helpful it is, and it's not really that cumbersome, right? It's a whole lot less cumbersome than fighting a denial. All of a sudden, people are like, don't ever take this away. But that takes at least 6 months, 9 months, sometimes a little bit longer, right? If you don't have a strong communication channel with your people and you're not promoting it, you're not supporting it. And I will tell you, if the leadership gets a little wishy-washy or ouch about it, if they let those 3 people out of 100 and however many come in and get into their head about, "Is this really a good thing? Why does this person keep showing up?" They start to lose their belief and their passion in it, it can all go out the window pretty quickly.
What's really, interesting about the conversation, right? I was 17 years into a career before I saw my first ounce of quality data, right? So you think about this, like if an advisor is listening to this or an employer is listening to this and they're like, well, wait a second, this quality score stuff, I would venture to bet 97 out of 100 advisors have never seen what it is that we're talking about. So that's number one. And then, if you remember, 2 years ago, I had vocal cord surgery, and you gave me the top 5 surgeons. I put my happy behind on an airplane and flew out to Las Vegas to have my surgery because this person specialized in polyp removals on a vocal cord. So what's interesting about that same conversation, if you take the law, practice, there are people that are buying their services who did the review of who's the best for this type of law. And like, I would go to that attorney for that type of law, but I wouldn't go to that attorney for that other type of law. And you do that. We do that with cars, but nobody thinks about doing this in the healthcare perspective. And I kind of want to switch the conversation of, okay, now quality, the better care, the more advocacy, the logical brain automatically starts thinking, well, wait a second, if I'm buying the best surgery, best, highest value surgery. I am adding this team of nurses. They seem expensive, that my costs are going to go up. Flip this conversation and now talk about individual patient scenarios, but also how does this aggregate to the macro for an employer? Are they saving money in this, or is this just a warm and fuzzy? I'm giving my team more hand holding, more concierge white glove. Talk to me about that.
Yes and yes. I love it that you brought up Vegas because the question becomes, do you wanna be the casino or do you wanna be the gambler,
Mm. Yeah.
right?
Right.
Here's the beauty of the US fee for service healthcare system. And people do not understand this because they think Bentley quality, Bentley dollars, you go quality, you go dollars. That's not how healthcare works.
Right.
It's the exact opposite. The higher the quality, the lower the cost because it's fee for service. So if I get you to the best doctor, the best surgeon who cures your condition quickly, efficiently, effectively, without complications, without needing prolonged therapy, without needing to go back and do a second surgery, guess what? Your costs are drastically lower. So, do you want to be the casino or do you want to be the gambler? My role is to come in and stack the deck in the favor of the patient and the employer. That's not the role of the traditional status quo system. That's not the role of the hands-on provider even. You gotta understand, over 70% of physician practices are now owned by hospitals or health systems that are businesses. They are not independent practitioners, they're employees of a business. The role of the status quo system, the role of the healthcare system is to stack the deck in favor of the provider of the care and the insurance company, not to stack the deck in the favor of the patient and the employer. So I just come in and I flip that deck over. and say, listen, here's what the science says, here's what the math says, here are the options that you have, right? Because as nurses, we also look at things holistically. We look at social determinants of health. We look at education level. We look at financial resources. We look at religious components. I mean, you and I had that case, Lester, where the stop loss wanted to put a huge laser on the patient. And I'm like, take the laser, take the laser. And they're like, he's going to get a transplant. And I'm like, take the laser. And you're like, you're crazy. I'm like, he's never going to get a transplant. He's a Jehovah's Witness. Take the laser, right? So, but if you don't have somebody who's hand-holding and working with your people that are on your plan, the human beings that you're really here to serve, that we as healthcare practitioners are here to cure, if we're not coming in and embracing them and hand-holding them, then how do we take advantage of the fee-for-service system and flip it on its head?
So let's boil this down. You said one of the gals who stood up in the law firm had the gallbladder, and they were going to go here. You ended up going over here. Are we talking a couple of bucks, $2, $3? Talk to me about the financial aspect of better quality, which to me kind of makes a lot of sense when you start thinking of the person who does 1,500 knee surgeries gets better at it than the person who does 200, right? That just kind of makes sense in regards to like, I do it better, I see more, I do it faster, I'm under anesthesia less, I buy more nuts and bolts and, all of those things. I probably have my own team that sees more of it. So it's just more efficient. So that completely, it's like unit cost, right? More units equals lower unit cost. That makes sense. But talk to me about, because I think that's the thing about it that I was so shocked of when being able to see it now side by side and be like, this one costs this and this is costs this. What? And so talk to me about that gallbladder and let's talk about a couple of examples like that.
So we saved that plan over $20,000 just on the cost of the surgery. And that's assuming that the original surgeon didn't have any complications or problems, just the surgical cost, right? So 20 grand off the top. That patient had a $5,000 deductible, embedded deductible with an 8 or so $1,000 out of pocket maximum. So we really saved her at least 5 grand out of her pocket by saving the employer 20 grand. They were willing to cover it at 100%. We also saved the provider from having to chase the patient and send it into collections and, give up a percentage to some collection agency. Everybody walks away happier in that scenario and more cost effectively. But if you look at it, I mean, we've got example after example after example. No, just we have a company in Northern Ohio, very rural area. Their main focus of business is stamping out the steel components that are used to make tanks. So government contracts, right? 2 counties away is their main competitor. And so they'll win a bid and employees will come here and they'll work here. And then next bid comes along, guy 2 counties away will win that bid, and he'll offer them 25 cents an hour more to come to work for him. So their talent pool leaves, goes to the competitor, and they were doing this back and forth of their key talent, right? Competitor, 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 competitor. All of a sudden, they're like, what if innovative broker walks in? What if we could offer free healthcare? Right? We'll waive your deductible, we'll waive your copay, just call the nurse, follow the nurse's guidance. What if we did that? And all of a sudden, this employer becomes the employer of choice. And it took them about 9, 10 months to get everybody adjusted and to see good ROI on it. By year 3, not only were they waiving deductible and copay, but they were waiving premium for employee-only health plan. They took out billboards and said, "Want free healthcare? Come to work for us." All of a sudden, they get to pick the top talent because they are the employer of choice, right? Talk about trucking. Talk about right now a competitive industry. We've got a trucking company headquartered in Michigan. We have kept their per employee per year claims cost flat for at least the last 3 years. Flat. Tell me any other employer who's not having a hike. Oh, I forgot to mention, year 1, we cut their claim spend in half by getting better care for their people. Their truckers know that doesn't matter where they're at in the country, if something goes wrong, call the nurse, call quickly, call early. Don't wait until you're so sick that you have to go to the ER. Call the nurse, let the nurse guide you. Just in the number of times that we tell them, you know what, your telemedicine vendor could help you with that. And let me Google real quick where the closest pharmacy, oh, Walmart has the best price for that, right? Walking them through that decision making process and just being there to help them. It's amazing what you can do with your health plan and how it impacts the lives of the people who are the lifeblood of your
That's your
business.
business. Yeah, no, it's such what's really interesting, and as we wind up here, I guess I'm shocked, but I'm not, right? Like, I see the books on the back there, right? And it's interesting when you get at this degree of our careers, right? It's like, I don't know that I thought about it for the first 15 years of my career. And I was working on bigger accounts because I was working for a global insurance consulting firm. My clients were bigger, but most of the time, the decision and the conversation was made by HR. There was some economic conversation, but, like, what can you do, right? And I was putting on on-site clinics. I was self-funding before self-funding was cool. I was doing all of the things, but you didn't have the levers to pull like we have now. And then I look at this now. Healthcare back then might have been a top 10 or 15 expense. Now it's a top 2, maybe 3 if they're lucky. Talk to me about, the audience right now listening is the CFO and the CEO. They're the organization. They're sitting here right now. They're renewing January 1st. And they're like, oh my God, I just saw another for the however many year, 8, 10, 12, 15, 20% renewal. What do you talk to them about? Like, what do you say to them?
Well, what I typically do is I walk in and go, okay, which one of you are going to fess up that you or somebody in your family has something going on with your health right now today? Because there's always somebody in that boardroom who has something intensely personal that's going on from a health perspective. And then the next thing I ask them is, has your insurance company reached out to help you?
Mm,
And 99% of the time, the answer to that is no. And so I open up my laptop and I go, okay, which doctor are you going to? Let's look at their quality score. What facility are you utilizing? What medication are you on? And I just give them a little taste, right? It's the Sam's Club sample
right.
of this is what real healthcare advocacy and health plans are supposed to do. Because really, let's face it, they've had those increases year over year. They've been budgeting for those increases. They have decided that it is just the cost of being an employer. And they stamp it once a year, and it's just like the lease on their office space. This is what it costs, and they don't think there's anything they can do about it. And then once I've shown them, okay, here's how somebody would really love you through that situation. And oh, by the way, it would become free for you as the patient. And the reason you as an employer want to do that is because by me moving your gallbladder surgery from there to here, I just saved you $20,000. Then the light bulb starts to go off for them that, wait a minute, I can take better care of my people and my business, right? It boggles my mind. You will scrutinize the price of paper clips,
Mhm.
but you're not looking at healthcare, and it's just because you've been lied to, and it's not your fault you got lied to, it's not your fault that you believed the lie. Everybody in the world has been believing that lie since the 1960s, right? So, but Now that you know, and what are you gonna do about it? That's the challenge.
Yeah, I always liken this conversation because again, I always thought like I was a little smarter than the average bear for the first 15 years of my career, but I didn't know half of this stuff even existed. So it's for me, it's the Spider-Man quote, right? With great power comes great responsibility, and this knowledge that this exists is your power and now is the responsibility. So now what are you going to do about it? So with that kind of leaving the audience, if somebody says, "My gosh, this is amazing," is there some sort of analysis or some sort of way you could show somebody like, "Hey, top quality and like how much this could save"? Is that something that you could do for the audience members if they're interested?
Absolutely. I would tell them, "Get in touch with you, share as much data as they can." I can do for an individual person, right? Like I said, I walk into the boardroom, which one of you is gonna fess up? You've got something going on. We can look at their canned carrier reports. We can use AI to do an analysis and some prediction, and then put some clinical underwriting on top of that. So there are lots of tools and resources, but if you're an employer, you've probably got somewhere in your electronic files the last canned report that you got from your carrier that tells you your admits per thousand, your average length of stay, your hospital days utilized, your top 20 drug spend, your, yeah, right? It's a canned report.
Yep.
Send that over to Lester, right? Let's work through it. Let us look at it and we can come back to you and say, listen, your admits per thousand were here, your average length of stay was here, your bed days were here, your maternity cases were here, your ER utilization was here. And let us walk you through that. If you don't have that, then you've got a census, right? You've got a list of who all your employees are. Go into your payroll system, pull out a census, send it over to Lester. Let us run it through some AI. We'll create a virtual report using AI. Then we'll apply some clinical underwriting on top of it. And we'll come back and we'll say, listen, in your population today, here are the pain points, right? You've got a huge number of pregnancies. Well, we know that we can cut the risk of premature birth in half. Validation Institute published the study. It's certified. We know that is true. Let's talk about the maternity management program, right? You can do transplant, you can do cancer, you can do NICU babies, you can do ESRD and dialysis, you can do diabetes, you can do acute care issues, you can do chronic care issues, and we'll break it down for you and help you understand here's where your opportunity lies. But understand that's the key differentiator. It's customized to you and your employees. You don't need to if if you have all young healthy men on your plan, you don't need a diabetes program, right? So pick and choose what are the pieces that make sense for you and your population.
Love it, love it. Deb, if somebody wanted to learn more about AIM, follow you, learn some more, where should we send them?
Go to LinkedIn, find me there, Deb Alt, AULT, or go to AIM dash like the minus sign M.com. It's a good place to start. But really, they need to tap into somebody like you, Lester. I love talking to folks, but this is getting such momentum that, I'm typically out speaking and big audience kind of stuff. They need to tap into somebody like you to really help them get that basic level of understanding and knowledge.
So we'll include contact and some links in the show notes. Deb, thank you. I think the thing that like I was tired when I got on this call, and now I want to like punch a wall. Like the thing that like frustrates me in this whole thing, right, is the number of employers that because it's 10-1, their normal status quo scenario got them an 18% renewal because their broker's magical. They got it down to 9. They made some plan design changes and they got it to 3. They're taking some more money out of people's paychecks and it's rinse and repeat. And like, knowing what we started with, right? The patient in mind, when gas is more expensive, strawberries are more expensive, everything is more expensive, and people are literally cutting 39-cent coupons for lima beans out on Sundays, and people are going to just let the second largest corporate expense go through
Yeah.
while saying it's just an extra $1,000 on a deductible or an out of pocket over here. I mean, the ability, and that I hope, and my just wish is that everybody took this and says, the definition of insanity is thinking that this is going to change, because it's simply just not. The economics are not aligned. The incentives on compensation's not in line. None of it is aligned. So, Deb, thank you for shining that light on what is possible. Change, absolutely, but you can't get a six-pack eating Twinkies. So the reality of it is you're gonna have to change if you want a better outcome. So thank you for being an advocate. Thank you, your nursing team. Obviously, we have business together, and you guys do a phenomenal job. It is change. So, it is one of those things that's like, hey, you're not gonna become a better basketball player unless you work at it. You're not gonna improve the health of your population unless you ask them to do something different. It's just common sense.
And it's never too late, right? I know we're beginning of October and you
Right.
think January is here and we're doing open enrollment in 2 weeks. Fine, do that. But then November 1st, let's start talking about making a change February 1st.
Or right,
It's never too
push
late.
back open enrollment. I mean, like, we put these timelines on because it's just the business. So anyway, Deb, thank you so much. For the audience, this is something that I can assure you, as somebody who's been in the business now 24, 12, man, we're going on 24 years. Man, these gray hairs on my beard, I have earned every cent of them. Um, this is something I would tell you, whether you're working with a very large advisory firm or you're working with a local independent. 8.5 out of 10 advisors don't know what we just talked about. And so if you're an employer and you're listening to this, this is something, share amongst your community, all of that. And if you're an advisor and you heard this and you want to stop being the Grim Reaper, then I think that this is the case. And so I love the opportunity that we get to have these conversations, because it allows us to do exactly what the title of the podcast is disrupt the way it's doing, not because of our own economic purposes. We'd make way more money selling Blue Cross. It is for the why this happens, and that's everything that we care about. So, Deb, thank you so much. Thank you for shedding the light, and we'll have you on again.
Awesome. See you soon.
All right, guys, thank you so much for listening. Hit a share, hit a like, make a comment, ask a question, and you'll see in the show notes, a link to a page that would allow you to raise your hand if you want that analysis that Deb talked about. So, Deb, thanks again. Audience, thanks again. And we'll see you next time on another episode of the Disrupt Healthcare Podcast.